a 45-year-old female with a history of breast cancer presents with mild right-sided pleuritic chest pain. I am showing you an upright posteroanterior chest radiograph and a right lateral decubitus radiograph. Describe the findings.
On the upright chest radiograph, there is an apparent elevation of the right hemidiaphragm. However, the peak of this pseudo-diaphragmatic contour is displaced laterally toward the chest wall, and its medial aspect appears flattened. There is no classic blunting of the lateral costophrenic angle. On the right lateral decubitus radiograph, a layer of free-flowing fluid is clearly seen layering along the dependent right lateral chest wall, measuring approximately 2 centimeters in depth. These findings indicate a right subpulmonic pleural effusion.
What are the key radiographic features of a subpulmonic effusion on a frontal chest radiograph? And how much pleural fluid is typically required to blunt the lateral and posterior costophrenic angles on upright films?
The key features on a frontal radiograph are pseudo-elevation of the hemidiaphragm, lateral displacement of the diaphragmatic peak, medial flattening of the contour, and on the left side, an increased distance between the gastric bubble and the lung base of greater than 2 centimeters. To blunt the lateral costophrenic angle on a posteroanterior view, at least 200 milliliters of fluid must be present. On a lateral view, only 75 milliliters is required to blunt the posterior costophrenic angle, which is a more dependent space. A lateral decubitus view is the most sensitive, detecting as little as 5 milliliters.
How are pleural effusions classified based on pathophysiology and biochemistry? What are the two most common causes of an exudative effusion, and what is the next step in management?
Pleural effusions are classified as transudates or exudates using Light's criteria. Transudates are caused by systemic factors like congestive heart failure, nephrotic syndrome, or cirrhosis. Exudates are caused by local inflammatory processes, with infection and neoplasm being the two most common causes. The next step is a diagnostic ultrasound-guided thoracentesis to obtain pleural fluid for biochemical analysis, cell count with differential, microbiology, and cytology to evaluate for metastatic breast cancer. I would coordinate with the oncology team for the procedure.